Welcome back to this next video in which we are discussing cataracts and cataract surgery. So in the previous video we discussed what a cataract actually was, and we saw that indeed a cataract is a cloudy lens. So the major cause of this is old age. As we age, something seems to happen to the crystalline proteins in the lens fibers, and this results in the lens no longer allowing light to move through it, no longer being transparent, but instead becoming opaque. And this can become so bad that it leads to complete blindness in the affected eye. So we're now going to talk about cataract surgery, and in cataract surgery the basic principle is that we're going to remove the cloudy lens, we're going to remove the cataract, and then what we're going to do is replace it with an artificial lens, and that will hopefully improve vision. Okay, so this operation can be extremely simple and it can be extremely quick. It can be 15 minutes if it's an extremely simple case, but if it's more difficult for one reason or another to remove the cataract, then it can take up to an hour. Now it's done in day surgery, so the person having it done can come in during the morning and then they can go home after the operation has been done, so they don't need to stay in hospital overnight. In addition, it's not done under general anaesthetic, it's done under local anaesthetic usually. Obviously, if the patient was extremely worried about having it done, then there would be the option of having it done under general anaesthetic, provided they were healthy enough to have a general anaesthetic. But usually it's just done under local anaesthetic, so the person is awake and conscious throughout the entire thing. Okay, so let me now describe then to you the process of cataract surgery, and I'm only going to go over the basic bits. We'll miss out certain steps that are undertaken. Okay, so the first thing is that we are going to want the pupil to be as dilated as possible, because this is our access for the lens. In order to remove the cataract, we need to have access to the lens. Going back to our anatomy, how are we going to get to the lens? Well, we're going to go through the cornea, and what we want is the iris to be as dilated as possible, because then the pupil will be massive and we just have direct access then to the lens, or the cataract as we can now call it. So we want firstly to give them something that will dilate the pupil as much as possible, so that we have as good access as possible to the cataract that we're trying to remove. So the drug that is usually used as an eye drop preparation is phenylephrine, and this is an alpha-1 agonist, and I'll just explain to you how this is useful. So basically the muscle of the iris, it has two components. It has a dilator component and a sphincter component. So if I just draw out the iris here, so like so. So this is the iris, here's the pupil. So there are two muscular components to the iris. There are muscles that go round in circles, so rings of smooth muscle cells that form circles like so, and these are known as the sphincter pupillae muscles. So the smooth muscle cells that are in circular arrangements like so, these form the sphincter pupillae muscles. On the other hand, there are also strips of smooth muscle cells that go radially outward in this way, and these are known as the dilator pupillae muscles. Now, these two groups of muscle cells, they have completely opposing actions. So if you think about what will happen if the sphincter pupillae smooth muscle cells contract. If they contract, then the circumference of these rings of these smooth muscle cells are going to decrease. And when the circumference of those rings decrease, just like what we discussed for the ciliary body, the entire diameter of those rings is going to decrease, and that's going to cause constriction of the pupil. So the sphincter pupillae, as the name suggests, that's going to constrict the pupil. So we do not want to activate the sphincter pupillae muscles. The dilator pupillae muscles, if you think about what will happen if these contract, well, if they contract, these arrangements of smooth muscle cells, then they'll become shorter. These lines that I've got here, these radially going lines of smooth muscle cells, and therefore they'll pull the pupil outwards. They'll reduce, they'll increase the size of the pupil. I hope that's reasonably intuitive. If all of these contract, then they'll pull the pupil outwards like so and expand the pupil. So we want to activate the dilator pupillae muscles. And luckily there is a way of activating the dilator pupillae muscles without activating the sphincter pupillae muscles. The sphincter pupillae muscles, these are activated by acetylcholine working on M3 receptors. So the parasympathetic nervous system can release acetylcholine onto the iris. This will work on M3 receptors on the sphincter pupillae smooth muscle cells, and that causes pupillary constriction, whereas the sympathetic nervous system can release noradrenaline onto the iris, and this will work on alpha-1 adrenergic receptors on the dilator pupillae smooth muscle cells and cause enlarging of the pupil, pupillary dilatation. Okay, we are going to give a drug which is an agonist for alpha-1 receptors, but which will not activate the M3 receptors on the sphincter pupillae muscles, and that is phenylephrine. So phenylephrine will activate the alpha-1 receptors on the dilator pupillae smooth muscle cells, causing them to contract, and that will cause dilatation of the pupil. So initially we give phenylephrine as an eye drop, which will end up causing pupillary dilatation. Okay, so that's the first step. Then the next step is to give a local anaesthetic so that they're not going to feel any pain. Now, this is done in two stages. Firstly, you give a topical local anaesthetic, which will just be in the form of an eye drop, and that's to numb the pain of giving the local anaesthetic, because giving the next local anaesthetic. So they're both local anaesthetics, so I'll just put this as a little title. So here we'll talk about local anaesthetic. So number 1, we'll have phenylephrine. Step 2 is the anaesthesia stage, so local anaesthetic needs to be given. So as I say, the local anaesthetic stage is going to be split into two stages, two sub-stages. The first sub-stage is just to give a topical local anaesthetic, a local anaesthetic that you can just give as a form of, in the form of an eye drop. And usually the one that is used for that is proximethicane. So we firstly give proximethicane as a topical local anaesthetic. So that's just as an eye drop into the eye. Then what we're going to give is we're going to give what's known as a subtenons local anaesthetic, and this will be lignocaine usually, which is also called lidocaine in the States. So lignocaine is the name used still in England, lidocaine is the name that the States wants us to use and hasn't quite got its way yet, but probably will get its way later on. So lignocaine or lidocaine is the one that's going to be used usually for the subtenons local anaesthetic. Now what does subtenons mean? Topical is very obvious, that's just an eye drop into the eye. Subtenons is going to have to be given by an injection, and this is going to be underneath the tenons capsule. Now, tenons capsule is something that I haven't introduced you to yet when we've discussed the anatomy, so let's just go back to the anatomy of the eye. So, something that I didn't tell you about at the time is that the sclera of the eye is contained within another outer layer, inside a capsule that surrounds the eye and protects the eye, known as tenons capsule. Now, you can actually see tenons capsule. It doesn't cover the portion of the eye that is actually usually visible. It covers the portion of the eye that isn't visible. So, tenons capsule is this connective tissue capsule that's going to cover the surface of the eye, like so, the portion that you can't see here. Okay, now you can actually see the tenons capsule if you get someone to look in the right direction. So if you get someone and stand them in front of you, or you can try doing it on yourself, but it's best if you get someone else to do it for you. So stand someone in front of you and get them to look right into one of the corners of their eye. It doesn't really matter which one you do, but you could get them to look right the way up here, and then if you look down here, then you'll just start to see tenons capsule appearing down here. So if you get them to look right up here, they'll move their eye in this direction, then you can just start to get the edge of tenons capsule visible, and it's the yellow that you'll see. So the sclera is very white, but then if they look right up here, you'll start to see a little bit of yellow appearing here, and that is what is known as tenons capsule. So it's a capsule that surrounds the sclera of the eye in the portion of the eye that you can't usually actually see. So, a sub-Tenon's local anaesthetic is an injection that goes underneath Tenon's capsule, but above the sclera. So what you're going to do is you're going to get the person to look up into the corner of their eye, exactly what I've just described to you. Then the anaesthesiologist will be able to see the beginning of the Tenon's capsule down here, and they'll then get their needle and stick it in between the Tenon's capsule and the sclera. So they'll go into this space here and they'll inject local anaesthetic into this space between Tenon's capsule and the sclera, and that's what is meant by a sub-Tenon's local anaesthetic. So that's the one that's really going to remove the pain. It also generally paralyzes the eye to some extent. It will stop the eye muscles being able to move the eye. Okay, right, so that's the sub-Tenon's local anaesthetic. So now the person is painless, they're not going to feel anything. Let's now discuss the actual cataract operation. So now, step 3, after local anaesthetic. What we're now going to do is make our starting incisions in the cornea. So usually what is made is 3 incisions. So I don't know how to show this. I'll draw a new picture for you. So let's say we've got a picture of the eye here. So of course you'll put apparatus in place to hold open the eyes. You'll have something to hold open the eye. So you've got the person's eye here that's had the local anaesthetic injected into it. And now here is the iris completely dilated now, like so. So you've got a massive great pupil, and then you'll be able to see the cataract hopefully behind here now. Now in front of the iris you'll have the cornea. I don't know how to show this. I'll just sort of draw it like so. So the cornea will be all over here like so, covering up the iris here. So our first incision needs to be into the cornea so that we can get our equipment into the cornea. So usually the way it's done is that you make 3 incisions, one large one, and then around the one large one, it doesn't really matter exactly where you put these, just somewhere that's convenient. So around the large one you then have 2 accessory ones. So this is so that you can insert in tools. Now generally the surgeon might want to insert in more than 1 tool, which is why we've got accessory incisions as well. So we can fit in a maximum of 3 tools here to be working with. Okay, so we make our initial incisions. So step 3 is to make the incisions in the cornea. And now what we can do is we can actually begin the removal of the cataract. So we can insert in tools into the anterior chamber. They can go through the pupil into the posterior chamber, and then they'll meet the cataract. So what's the first thing that we do then? The first thing is we chop out a hole in the anterior capsule of the cataract. So remember when we talked about the anatomy of the lens, we talked about how it has a capsule here, like so, and then the centre. Now, the idea with a cataract operation is that we're going to take out the centre of the lens here, and we're going to stick in, instead of the natural centre of the lens, an artificial lens inside the capsule. But the idea is that we want to keep as much of the capsule as possible, so we only want to make a small hole in the front of the anterior capsule so that we can gain access to it. Then we'll remove all of the centre of the capsule, and then into this capsule we will inject in our new lens, which will then unfold and sit in there. So the idea is that we're going to maintain the capsule so that we can sit our artificial lens inside that capsule. We're just going to remove all of the centre, which is the bit that has actually gone cloudy. So what we then do is, getting to the lens here, and I'll just draw the lens here, we make a circular incision in the anterior capsule of the lens, like so, and this is known as the rhexis. So we create the rhexis, which is a circular hole basically in the anterior capsule of the lens. So just to show you that this is indeed the anterior capsule of the lens, I'll colour it in blue again, which is the colour I previously drew the capsule of the lens in. So we've gone in, we've made a hole in the anterior capsule of the lens. We'll remove that circular piece of the anterior capsule of the lens out of the eye now, and now we have access to the centre of the lens, and we can remove all of that tissue. So, step 5, once we've created the rexus, we're now going to remove all of this tissue that has gone cloudy, all of the centre of the lens. And this is done by a process known as phacoemulsification, or phacoemulsification, depending on how you want to pronounce it. So, phacoemulsification. Okay, so let me explain phacoemulsification then. So phacoemulsification refers to the destruction of the centre of the lens and the sucking out of it using ultrasound. So basically what you have is a little probe, a little stick effectively, and on the end of the little stick what you have is something that will oscillate at an incredible frequency. So this is capable of oscillating at 40,000 Hertz. That means it's capable of oscillating backwards and forwards 40,000 times per second. So an incredible feat. So this is going to generate ultrasound waves then. Vibrations that are at a massive great frequency are known as ultrasound vibrations. So this probe is capable of generating ultrasound vibrations, and these ultrasound vibrations are going to destroy the lens tissue basically. They're going to mash up the lens tissue into loads of little pieces, and then this probe will also have the ability to suck up the little pieces, to aspirate them is the fancy word for this. So not only can it emulsify the lens into loads of little pieces, but it can then aspirate the little pieces, and it will also have the ability to squirt in new fluid at the same time to replace the lens that we are removing. So it wouldn't do just to be removing stuff and not putting stuff to replace that stuff. So when we aspirate pieces of the lens, we do need to replace them with something to make sure that we don't get the lens collapsing. So we will replace it with fluid, gel generally. Okay, so phacoemulsification then. We're going to go in and we're going to mash up the lens effectively and suck it all out. Now this is done in an ordered way. You don't just go in there and feel around until you've got every little bit, and the reason that it has to be done in an ordered way is that you want to make sure that you do not damage the capsule. This is a very powerful device. It will mash up anything that it comes into contact with, and you do not want to mash up the capsule, because think what would happen if we mashed up the posterior capsule. So if I was uncareful and I put my probe onto the posterior capsule, then I get a hole appearing in the posterior capsule, and then the vitreous humour would start to leak through, and that's not good. We want to maintain the posterior capsule, we want to keep it intact, and it's going to be, remember, the nice new home where our new lens is going to sit. So we do not want to damage the posterior capsule, and for that reason phacoemulsification is done in an ordered way. So the way it's usually done is if I draw a picture of the lens like so. So let's say this is the portion of the lens that has got the hole here, the rexus. So this is the central portion of the lens that has been exposed. What we do is we firstly make a hot cross bun sort of trench in the surface of the lens. So you'll take your probe here and you'll work it along like this to create a trench in the lens. And then you'll do another one this way round, like so, creating a hot cross bun kind of pattern here. And then this allows you to break up the centre of the lens into 4 major pieces. So this is where it's a case of, hopefully this happens. If it's a lovely cataract operation and it goes incredibly nicely, one of the 15-minute cataract operations, then what happens when you do this, when you make these trenches in this way, is that the lens centre breaks into 4 pieces perfectly, and you then just sort of break each one of these apart one by one, and you know, if it's really smooth, then the centre just detaches away from the capsule. You have these 4 pieces, you just pull them away from the capsule and then break them up, and then you're not risking damaging the capsule. That's if it works beautifully. If it doesn't work beautifully, then what happens is these pieces end up sticking to the back of the capsule, and then the surgeon has to be much more careful and has to just gradually work their way down and breaking these apart. But the hope is that you you'll break up the centre of the lens into these 4 pieces like so, and that they just come away from the capsule, and you can then break them apart without worrying about damaging the capsule behind. Okay, so that's the phacoemulsification stage. So let's now presume that we have removed all of the centre of the lens. Now usually, even if it works perfectly, there will be some bits of the centre of the lens that are still attached to the capsule. What you do is you get a lighter probe to come back and pull those bits away. So you get rid of this phacoemulsification probe here now, and you will come back with just effectively an aspirator, a hoover effectively, that you can go around the edge of the capsule without worrying about damaging the capsule, and just hoover up any bits that are left over, so just aspirate them out. Okay, so that's the removal then of the cataract. Now what we want to do is replace it with the artificial lens. So where are we now? Number 6. So replacement. So the way this works is you inject the lens in. So let me firstly just draw a picture of what the lens looks like. So the lens is going to just be circular like so, but it's also going to have little structures that are going to help hold it in place. So it'll have a little sort of foot process like this on that side, and also another one on this side like so. And these little foot processes are known as haptics. Okay, so this is a haptic, and this is another haptic. And the idea is that you can insert this into the capsule, so the boundary of the capsule will be here, if you like, and these will push out against the edge of the capsule and hold the lens in place. Now, how do you actually get the lens in? Well, it's really clever. It comes folded up into a nice sort of sausage shape, rolled up into a sausage shape effectively, and it's just in a syringe. So what you just do is you insert your syringe in through your major incision here into the posterior capsule, the posterior chamber, not into the posterior chamber, into the actual capsule of the lens that you've now cleared out, and you just inject in your new lens here. And then once it's actually in the capsule, once it's come out of the syringe, it then unfolds, and the hope is that then you can just sort of, with a few little prods, guide it into the correct position. The haptics will then push out against the edge of the lens capsule and hold it then beautifully in position. And then you've got your new lens. Then all you need to do is close up these incisions, and the way that's usually done is, rather than suturing up, because they're usually very small incisions, so usually they don't require suturing up. Instead, what's usually done is you just do what's known as hydration of the wound, where you inject a little bit of fluid into the cornea where the wound is present. This causes the wound to swell, and that then holds the wound closed, because if the cornea around this area is swollen, then that wound is going to be closed. If you can imagine the two portions of the cornea on either side. So if this is the wound here, if we swell the cornea on both sides, then they'll push up against it and hopefully hold it closed. So what we do is we just inject a little bit of fluid into the portions of the cornea near these wounds, and that helps to hold them closed. It does cause cloudiness of the cornea, because having the fluid in the cornea disturbs its ability to conduct light, so it makes it a little bit more opaque, but that's transient. That will go away, and it will help to hold the wounds closed without the need for a suture. Okay, so number 7, I might just put it there, hydration of the wounds, or hydrating wounds, okay, to prevent them opening back up. And then the person is free to go. They'll have an eye patch over the eye. The phenylephrine will eventually wear off, but hopefully there shouldn't be any complications from the operation. Hopefully it's a very nice, simple operation, and they should be able to go home without suffering any complications. So the final thing then that I want to say is talking about the fact that now we have lost accommodation, which I promised to do at the end of the previous video. So remember, with the natural human lens, we can change the shape of that lens and thereby change the power of the lens. So if we want to focus things that are very far away from us, we can make the lens very long and thin, i.e. reduce its power, and then have those things that are far away being focused onto the back of the retina. Whereas if we want to focus on things that are very close to us, we can make the lens fat and globular, and then that will allow us to focus things that are very close to us on the back of the retina. Now we have a lens, this artificial lens, which is fixed. It can't change. And generally we set this up so that things that are about 6 meters away from the eye will be focused onto the back of the retina. So we generally pick a lens which has the correct power, and we calibrate it to the size of your eye and all the things like that, the curvature of your eye. We take a huge amount into consideration, and we calculate the sort of lens, the power of the lens, so that you will be able to see things that are around 6 meters away from the eye perfectly in focus. They will be focused perfectly onto the back of the retina. The problem then is things that are much closer. So for instance, reading, you're not going to be able so as well to focus things that close onto the back of the retina. So for that you will require glasses, an additional lens to help focus the light, to increase the power of the lens effectively, increase the ability to focus the light onto the back of the retina. So that's the general distance then that we calibrate everything to. We want it so that you will be able to focus light coming from sources that are 6 meters away from you onto a point on the back of the retina. Okay, right. So with that then we will finish this video on cataracts and cataract surgery.